Good afternoon. Welcome to today's Grand Rounds presentation. Please remember to sign the attendance record so you get credit for being here. And also please remember to fill out the program evaluation. And from the perspective of the CME committee, very importantly, if you could give us ideas in regards to future topics or future speakers, we'd be appreciative. Our speaker today is Dr. Nate Noble. Dr. Noble is a pediatrician. He did his residency at Blank Children's Hospital and moved on to the University of Iowa, where he did a pediatric development fellowship and subsequently did a genetics fellowship. He's here to discuss an interesting topic. His topic is autism, screening, treatment, and vaccine controversy. And please join me in welcoming Dr. Noble.
Thanks. Thanks, Steve. Thank you. All right. Well, thanks, everyone, for having me. Certainly, it's nice to get out of Des Moines, come to the land of the Cyclones. So thank you in advance for your stellar football season that you're going to have. Now, I trained in Iowa City, and I'm a Cyclone, so it was tough sledding. So, before we begin, maybe as kind of people mill in, I thought maybe it might be nice to, just by quick show of hands, today we're talking about, certainly it's a neurodevelopmental disorder that has a lot of controversy. Lots of tentacles come from this diagnosis and touch all kinds of people's lives. And so one thing I've learned to ask as I start these kinds of discussions is just by show of hands, just to give me a sense, how many people in this room have either directly or indirectly dealt with, cared for, or been impacted by an individual with autism? So like almost everybody. Excellent. Very good. So, and I always like to start with that question because this is a discussion that touches people's lives in a lot of different ways. Some of you have loved ones that you care for deeply who are on the autism spectrum. Some of you certainly have cared for children on the spectrum. And so my goal and hope today is not only to start this dialogue and to give you, I think, some good information, but also to handle it well, to try and shepherd this conversation well. I esteem these children, the children that I care for, highly, and that I hope that that comes across in the language that I use today to talk about this diagnosis. So with that, let's get started. Okay, so here's my disclosure. So as a developmental pediatrician and clinical geneticist, I'm lucky to get paid at all. I'm blessed to get a paycheck, so nobody pays me anything extra. Here's our objectives today, okay? And as we get to know each other and we spend this time together, one of the biggest obstacles that we're going to have to overcome is we're going to have to learn to speak the same language. Now, that being said, for those of you who are somewhat savvy in regards to the diagnosis and management strategies of autism, know that some of these terminologies, some of the things that we're going to agree to talk about today are going to change. And so I'll spend just a brief amount of time today talking about what that can mean. But here's a list of goals for today. I'd like to discuss the terminology, kind of demystify a few things so that you understand. When I say one thing, what does that mean? When you read it in a note or you have a friend who mentions that their child has been diagnosed with X, Y, or Z, what exactly that means from my perspective. I'm going to talk about the history of autism and to let us, just to look at when did we start calling this something and who started doing that. I want to talk about the prevalence. I want to talk about etiology. I want to talk about the clinical signs, identification, diagnosis, management, and then what resources are available. What is it that I spend the majority of my time doing every day in the clinic? So let's start with terminology. So as you can see up on our slide here, autism and autistic spectrum disorders have a fairly broad descriptive categories which we can sample from. Most of you in this room are fairly familiar with the full spectrum diagnosis of autism. And as we move forward in the talk, I'll explain exactly what goes in to make that diagnosis. But when you think about autism, you think about children who, again, a full spectrum diagnosis, they have core disabilities in the area of social communication, expressive language, and the presence of stereotypical patterns of behaviors. So those are children that, again, most people are fairly familiar with knowing the diagnostic criteria. People are often less familiar with the diagnosis of Asperger's syndrome. What exactly goes into that, and a brief conceptualization of that diagnosis, is a child who has every bit as much social impairment every bit as much, and the repetitive stereotypical patterns of behaviors, but that middle piece, that I didn't talk till I was 3.5, that piece is not there. They tend to talk on time, somewhat even in a precocious way, but it's the way they use their language. It's the intonation, it's the give and take. It's the understanding that when Dr. Noble looks at his watch, he wants to leave. That when I back away, you're standing a little bit too close to me because I'm uncomfortable. That's a big distinction. Pervasive developmental disorders not otherwise specified, and that's a fairly non-gratifying descriptive diagnosis. And I don't use it often, but what it means is this child has a lot of features of a spectrum diagnosis, but not enough to make a diagnosis of either Asperger's or full spectrum autism. Rett syndrome is a genetic diagnosis, MECP2. It's a molecular diagnosis. We can discover this by sending a molecular study. You think about microcephaly and regressive symptoms, particularly in females with hand wringing, primarily at around 18 months of age. I suspect that lumping that together in spectrum diagnoses is something that we won't be talking about in a year and a half from now. Child disintegrative disorder is just as it sounds. I've never seen it, but these children literally regress in their symptoms, but they don't have the stereotypical personal social struggles. So that's just terminology. We're going to review a little bit of that. History-wise, we're going to go 1940s, okay? Like a lot of scientific kind of, I won't say breakthrough, but in terms of a lot of different types of breakthroughs, I guess we'll say, throughout the years. Oftentimes there's not just one person having these kinds of discoveries. So in the 1940s there was two physicians, both psychiatrists. One is Leo Kanner on the left. Okay, of your screen you'll see him on the left. He was a psychiatrist at Johns Hopkins. And he began to describe, at that time, what would then turn into a full spectrum diagnosis of autism. These children that were, from a personal social standpoint, very reserved. They had significant expressive language delays and these repetitive and stereotypical patterns of behaviors, very disruptive. He began to describe, again, the full spectrum diagnosis of autism. Same time, Germany, Hans Asperger begins to describe similar struggles in children, but these children had a little bit different flavor because they didn't necessarily have that whopping expressive language delay. They talked, but they just didn't talk in a way that was typical. Prevalence. I'm going through these first ones fast because the meat of this talk is kind of in the middle. Now let's talk a little bit about prevalence. And before I get into prevalence, the reason that things are going to start to heat up, or they typically do at this point when I give these kinds of talks, people want to say often, why are we seeing so much more autism now than we were in the 60s or the 70s or the 80s? And we're going to talk about that, but I want to start that discussion. I want to prime the pump by telling you this. In the 1960s to the 1980s, we were using the Kanner criteria. Now, I'm not going to tell you exactly what that entails, but the point is we were using a criteria that we don't use anymore. From the 80s to the 90s, we start using the DSM-3, right? It's a book of descriptive diagnoses used by our psychiatric colleagues. Okay, so that's the 80s. The 90s, the DSM-3Rs, they put out a revised version. And in the 2000s, we come out with the DSM-4. In May of 2013, DSM-5. Okay, so we're like just about ready to turn the page to the newest chapter of this saga. But as you can see, let's look at prevalence per 1,000 children. 60s to 80s, 0.4 to 0.5 per 1,000 children in the United States. In the 80s, 1.5. In the 90s, up to 1.1, so it stays kind of steady. In the 2000s, explosion number 1, 6 to 8 per 1,000 children. Okay? Now, let's say all of us, this is the example, this is the word picture I use to help people understand this. When I grew up, I grew up in Northwest Iowa, and we had a fish tank. And my parents always said, you don't ever go in there, Nate. You stay out of that fish tank. Because I remember those little green nets that you use to like fish out the dead fish, right? If we took one of those and we all got into a boat and we drove around the local lake here, whatever that's called, we drive around and we have some beers and we just drive around because that's what we do because we're friends. And I hang my net over the side. About every 6 or 8 hours we're going to catch something. It's probably going to be very big, but we're going to catch it. That's like 60s to 80s, okay? And then we decide we're going to get a bigger net. And then we're going to get a bigger net, then we're going to get a bigger net. And then what we realize is that we're not the only people on this lake. There's all kinds of people. There's teachers driving around and principals, and there's people at the gas station, there's people at the supermarket, there's people at the mall. Everybody's throwing nets everywhere you go, and all of a sudden, you're finding people are catching a lot of fish. But the point is, we're throwing a lot of those fish back. Okay? So, I want to prime the pump with that discussion that I think one of the big reasons we're seeing an increase in prevalence is because our criteria has steadily broadened. We're bringing in more things and calling it autism spectrum disorders, okay? Not only that, but all kinds of people are throwing these nets. It's not just physicians and physician clinics, it's people everywhere. So let me unpack that a little bit more. So let's talk about explosion number 2, okay? So we talked about the DSM-4 and what happened. Now you're up to like 6 to 8 kids per 1,000. In 2012, okay, shortly after I started my new job in Des Moines, I started getting all these phone calls and emails based off the new Center for CDC report that now 1 out of 88 children, okay, 1 out of 54 boys, 1 out of 252 girls, or 11.3 out of every 1,000 children are now on the spectrum. So I get to Des Moines, I'm thinking, oh yeah, we can handle this, we're going to do just fine. All of a sudden, the wait list just blows apart, right? I've got 18 to 36-month-old speech delay coming out of my ears. I mean, they're everywhere. They're coming over lunch hour. They're coming in at 5 o'clock. They're coming in at 8. I mean, they're coming in all over the place. It's just raining. And I want to now transition to clean up the beginning of what I was talking about earlier in regards to why is this happening? So we talked about wider diagnostic criteria, and my hypothesis is that we have peaked, okay? We have peaked. We have broadened the diagnosis so much that now, from the 90s until now, we've got so many people throwing it that the market is peaked. This is 2007, right? Everybody's going to buy a house, which is a bad idea. I just got burned on that deal, right? But 2007, the market is peaked. It's saturated. Everybody's buying homes and selling them and making money. That's what's happening right now, okay? So my hypothesis is that market has peaked. So I don't suspect we're going to see this go higher. Okay, I think we're starting to see the waning effects of diagnostic criteria that, from my perspective, are a little too broad. Okay, now we're going to get to the DSM-5 at the end of the talk. I'm not going to get into specifics, but I think this problem is going to start to shrink again. We're going to start to say, okay, that's not autism, that's something else. Screening tools, we talked about this, everybody's using them. You put things in the media. You get people like Jenny McCarthy writing books. You go into Barnes & Noble and you go to like a section on, disabilities in children. They usually have kind of a, certainly a section. Most of the books that people are writing are about autism, for the most part. Unrelated disorders are getting lumped into this diagnostic, this descriptive diagnostic nomenclature of autism. People are saying, well, all kinds of different genetic syndromes have autism as a feature. And then lastly, public policy. When people start jockeying around with what we put into and what we take out of vaccines based off this or that or this or that or this, the tenor of society just goes through the roof. People just start to bubble over. So what is autism? What's the etiology? What's the underlying problem here? And I'm going to tell you what I always tell all of my families when they come to see me, because this is 70% of what we do. I get to that spot in the conversation where the phenotype is clear. We've documented the core criteria. We've done the appropriate presses, the kinds of things where I literally get into a child's zone and try and establish joint attention. Do you respond when I call your name? Do you participate in social and imitative play? These are things you can ask, or the things you can prompt children to show you. We get to that part of the conversation where the diagnosis is clear. I've counseled the family about what I think is happening here, and then I start to talk to them about what we're going to do. And this is the part where I say, autism is a genetic diagnosis. That's what I say. And then people say, what are you talking about? And then I say, hold on, just hold on. Before we get there, so I'm alluding to this here. Autism is a serious public health challenge. Heritable, but we do not know the genes. I'm going to earmark that. That's becoming less and less true every day. Heritable, we know the genes. Neurodevelopmental, but we don't know the lesion. Increasingly common, but we don't have a medical treatment. I'm also going to earmark that. Also becoming less and less true every day. autism is a genetic diagnosis. It's descriptive in how you document it. You're going to see when I do my notes. In the HPI, you're going to see, here's the paragraph where I tell you exactly how this child meets criteria. Then you're going to read in the testing section how I utilize different prompts and presses based off what's called the Autism Diagnostic Observation Scale to prove to myself that it's more than just, like criteria, criteria where I'm just listing them off and parents are nodding or saying yes and no. It's much, much more, I think it's much, much more difficult to tease out than that. So it's a descriptive in that way, but it's genetic in its underpinnings, and here's why I say this. So in monozygotic twins, identical twins, if you've got one twin that is diagnosed with autism, the likelihood that you're going to have the second twin also on the spectrum can be, in some studies, up to 95%. Now you can see, well, some studies is 36%. Yes, that's true. So there's a range. It's not a one-to-one correlation. But 95% in any study is pretty high. And what do monozygotic twins share? DNA, okay? Dizygotic twins. So they're fraternal, they're not identical, maybe like other children, so they share maybe 50% of a similar makeup in regards to how they inherited that from their parents, but they're not identical, up to, in some studies, 31% concordance. So the idea that this is genetic diagnosis to me is a simple point. But I find this is often a stumbling block for people because what do I want to do? I want to draw their blood. Multiple genes have been implicated every day. Every week I have PubMed send me updates on what's published in autism, and there's probably at least 60 articles every 7 days, most of which are just garbage. They're like the National Enquirer version of research. But there's some really good stuff that comes out, and I would say a large portion of those are new genes that have been implicated. Now, it's not going to be monogenic. It's not going to be one gene. Oh, here's the autism gene. That's not going to work any more than you're going to find the gene for height or weight. You're just not going to find it. These are multifactorial problems. But several chromosomes have been implicated in regards to deletions and duplications. Few sites are identified with any consistency, although I have 3 children that I care for in my clinic, all of which have the exact same genetic deletion, all of which have the exact same phenotype, all of which have autism as a feature, which is primarily how they get to me to begin with. It's genomic, meaning there's big changes, deletions in DNA, duplications in DNA. It's molecular, meaning it could be just one gene in one child that could cause this problem, and in another child it doesn't really involve the similar types of genes. And then lastly, it could also be metabolic, which is smatterings of the first 2 categories. And so that's what you worry about when you have children who are regressing. So sometimes you'll see, maybe you send me a kid, and I think they're losing milestones. And even if they were born in the state of Iowa and they have a normal newborn screen, I don't care. We just go for it. We get their blood, we get their urine, we make sure that this is not a treatable condition. Other theories, the second hit phenomenon. Now, how I explain that to people is much like the BRCA mutation in cancer. So you're born perhaps with one mutation that predisposes you to cancer, but you have a working copy. But then 20, 30 years go by, something happens to your one copy that is functional, and then what happens? You begin to demonstrate, you then become highly predisposed to developing cancer. This is not unlike that. We don't know which genes this is, but the hypothesis is that you have come out, you were born with perhaps one working copy of something. And then along the way, whether it's environmental factors, which we're going to get to, or other instances, for whatever reason, that working copy now is impinged and you lose that function. Usually around 18 months of age, kids start to regress. They lose their language skills. But there's other associations. Prenatal. Children I've seen with prenatal infections, drug exposure, perinatal, so threatened abortions, advanced maternal age, encephalopathy, the seizing infant, the floppy infant, infants with intrauterine growth retardation, certainly prematurity has a much higher incidence of autism as you compare it to the general population. And then lastly, postnatal factors that we can't really nail down. But is it vaccines? What do you think? What do you think Dr. Noble was going to say here? Nope. Nope, it's not. And it's not, I'm going to tell you why. I'm going to tell you why in 2 different ways. This is the bones, and then I'm going to give you the flesh. Okay? So, In 1998, a Lancet study came out that implicated 12 children with autism had some kind of autistic regression with colitis. There was this concern that perhaps this was linked to the MMR vaccine. As we all know, AAP, Institute of Medicine, Cochrane collaboration, all of these large bodies, evidence-based driven, have debunked this. It's a non-issue at all. That's the bones. And when I get families who are really into the bones, I say, look, hey, I'm happy to give this information to you. You want me to print out a stack of articles? I'm happy to do it. I mean, you're going to do with that what you want, but I'm going to honor what your family values, but I'm just telling you that's the truth. Here's the flash. I have 3 kids. Judah, Ezra, Alia, 6, 4, almost 2. I held every single one of those kids down. Every single one of them. Hold their legs, try to be a good guy, try to help the nurse or whoever was doing it, and watched them all get injected with these things. Doing what I do every day, I did that. Because I absolutely believe that there's no data to support this. And this is what sometimes I'll tell the families. I don't mean to be offensive here, but this is what I'm going to tell you. There's as much evidence for the link between vaccines and autism as there is to the existence of the Sasquatch. If you want to follow that road, you follow it, but you might as well start pulling articles on Bigfoot. Let's just do that, okay? And I don't mean to be derogatory. I'm not trying to be offensive in that. I'm just saying that's how strongly the evidence is, as opposed to this link, okay? We've done great damage in allowing this to propagate. And professionals do it. They'll be like, well, I'm not really sure. I don't think it's that, but just stop right there. If I'm a parent in the clinic, that's enough. I don't want to do this. Forget it. And I find that over and over, particularly in the Des Moines area, where people will say, yeah, well, I met with this doctor and they weren't quite sure. And I'm just like, what's not to be sure about? I'm certain. I'm telling you with certainty. So, etiology. Thimerosal. Maybe it's thimerosal. Maybe it's not MMR. Maybe it's thimerosal, the mercury-based preservative. Who knows? So, in 99, they request removal, right? Causes a huge uproar. People are freaking out, right? They think, well, let's just get this out of there because it could be a concern. We're not really sure. Public outcry, people are going nuts. 2001, completely removed, okay? But here's an interesting point. In Denmark, in 1992, they removed this. They totally removed this. And you watch the incidence of autism in that country, and it does not go like this. It goes just like it goes here. It just keeps on going, right? Because of criteria, because of the nets. But there's, certainly there's analysis, they don't find this link. I'm not going to beat this anymore. I just want to own that. I continue to be surprised at how people will propagate that. And I just want to tell you, there is no link. But let's talk about what is a cause. Let's talk about causes. Let's talk about links that are real. Chromosomal, 5% on estimates. This comes from the genetics community. Gene disorders, single gene disorders. If it's Rett syndrome, if it's any number of different genes. I mean, there's 25,000 genes. There's hundreds of thousands of disorders that go with these. But gene disorders in general, 5%. Copy number variants. What do I mean by that? Deletions in the DNA, duplications in the DNA. By and large, when you duplicate things, it doesn't make a big difference. Everybody in this room has deletions and duplications, and you all seem like you're fairly reasonable people, right? But it's because what's been duplicated or deleted to you doesn't really matter from a neurodevelopmental standpoint. But when you duplicate or delete other genes or other regions of the genome that unfortunately are somewhat predisposed to deletions and duplications, it can be a mess. It can be just a phenotypic disaster for children in particular. It can involve heart, eyes, kidneys, spine, cognitive, all these different issues. It has implications such as recurrence risk. Sometimes parents are balanced carriers and they don't even know. Your only hint is, yeah, we lost 5 pregnancies before this one. Yep, that's a red flag, especially when you're dealing with a delayed child as well. The likelihood that family could be a balanced translocation. So they have a part of their chromosomal material that's just been flipped and changed, but it's like I give you $1, you give me $1, we both got $1. But then they have a kid, and that kid's got 50 cents. Something happened. Some material is lost in translation, and children can be predisposed to the loss of material when parents have changes that they don't know about. And why is that important? Because it can happen again and again and again. And the child that they do have, the child that is phenotypically normal and not on the spectrum at all and doing great, getting A's in 7th grade, could be a carrier of a balanced translocation. The implications go very deep. So, copy number variations are discovered on a test called a chromosomal microarray. Guess what insurance won't cover? A chromosomal microarray. I am telling you, my mind has been blown by the state of insurance. I mean, I'm like preaching to the choir here. But I'm like on the phone with Walmart. I'm like, hey, look, the reason I want to start with a microarray is because it's 20% of these kids. They're like, no, you have to do a metabolic workup. I'm like, you mean the 1 out of 100,000? That workup? You're not going to find anything. But my point is that even though we know how best to approach these things, we know what most of the causes are from a genetic standpoint, we're still 10 years behind in insurance. Like, I can't even believe it, even more. These are experimental therapies, even though they've been out for years. Evaluation tools. 75 or 80% of the children that I'm evaluating are idiopathic. So I'm not trying to blow smoke here and say, oh yeah, I'm going to figure this out every time. I am not. I'm not going to figure this out the majority of the time. I would say in our clinic, I'd say 20% is probably accurate, depending. But there's other things to consider that can tilt the scales. Is cognitive impairment. I meant to put intellectual disability instead of mental retardation. MR is what I'm alluding to by mental retardation, but the new term is intellectual disability. Is that present? Are there dysmorphic features? Is there a family history? Are there hard neurologic signs or symptoms? These are things that make me more aggressive to do imaging, more aggressive to get genetic testing, and not to take no for an answer. So, let's talk about clinical signs, all right? I want you to watch this video. Some of you have seen it. Some of you, oh, I'm sorry, that's the wrong one. Some of you have not.
Charlie bit me. Ah. Ouch! Ouch! Ouch, Charlie! Ouch! Charlie, that really hurt.
Okay, who's autistic? Who's autistic in this video? Who thinks it's the bigger kid? Who think it's Charlie? Who's chicken? Okay, now this is a trap. Okay, neither of these kids are autistic. I give this talk all over, and I will tell you, the rooms are divided, 50-50. 50-50. Most of you are like, oh yeah, this kid's not autistic. Charlie's not autistic. He's mean, but he's not autistic. And the older brother's dumb, but he's not autistic. Okay? Impaired social relatedness. And I want to paint a picture for you about what I mean. Okay? Because I always thought, oh, the DSM criteria are there, we'll just go through it, this is easy. But I'm really learning this is an art. Like how you get at this in kids. There's the criteria and how I ask the questions, but then there's the prompts. So I'll come into a room, and I mean, if you ever have seen me in a clinic and you see how I do this, it's odd. I'm an odd person, okay? So I'll come in and be like, hey guys, my name's Nate. Dude, I'm done with you. Hey buddy! Woo! Hey man! You see hey, is this your mom? Hey, will you give this to her? Give this to her. Ooh, you're a good looking kid. Why don't you look out the window? Did you look out the window? Hey, do you like cars? Do you like cars? Right? I mean, I just hammer them with new and novel, new and novel, new and novel, new and novel, okay? Because I have to know right away, where is this interview going to go? Which way is it going to go? I'm looking for impaired eye contact. Now, I have lots of mentors in medicine, got horrible eye contact. Some of you in this room have horrible eye contact. You don't have autism. You're just passive aggressive. Right? You have autism. But so we get hung up on this. Oh, they've got good eye contact. They can't have autism. Here's what I see every day. Johnny. Now that's eye contact. It's not awesome, but it's eye contact. And I see that all the time. It's not sustained. It's not I call your name, you instinctively turn to acknowledge another human being. Do you see? It's not just bad eye contact. It's how do you respond to a pointy-nosed, burnout doctor coming into your room just hammering you with new and novel? Difficulty with peers. Now what do? They're 2 years old. They're 2 years old. Were they in a bike club? Were they in soccer? I mean, it's just like some of the DSM is just dumb. I'm like, oh yeah, are you organized? How's organization for you? You good? Right? It's ridiculous. We're going to talk about ADHD, but it's ridiculous. Okay? But what I ask here is not, tell me about your friends. They're 2. They're 18 months of age. Parallel play is what they do. Right? Parallel play is what they do. They don't walk up to people at 2, 2.5 and be like, hello, I see that you're using the fire engine. May I use it when you're done? I'll be over here on my cell phone. Right? They don't do that. What I'm after is, hey mom, hey dad, you're on the playground. There's a group of kids. Everybody's going nuts, right? Your kid's off. He's off on the side. I get that. Some kid turns over a stone, and underneath the stone is the biggest spider anyone has ever seen. Kids are going nuts. You got 2 groups of kids in that situation. Kids running to it. Kids running away from it. Where's your kid? What's going on? They looking over their people's shoulders? What's happening? They going off on the side by themselves? Or are they not really either one of those, right? Because kids will stay off from social situations because they don't talk well. And they know they don't talk well. You see the difference? Autistic kids don't speak well, right? Communication's a big problem. Kids with expressive language delays don't speak well. Both of them stand off from the crowd. One of which does it because they know they don't fit in well. The other which does it because on some level they're just not interested. No, they're not bad people. They don't have that value yet. Lack of social and emotional give and take. I walk down the halls of this hospital. I have ADHD really bad, if you haven't figured this one out. I'm walking down the hospital. I won't go off a tangent, but I'm walking down the hospital. I see you. You see me. You remember I came and gave a grand rounds. You liked it. You want to say something to me. I see you coming. You smile at me. I'm thinking in my mind, oh, this is somebody I should probably know. I don't know them, so I'm going to do what? You smile at me, what am I going to do? Hey, how are you? Do you see? It's that give and take. If I smile at one of you, you're probably going to smile back. You're going to mirror it to me. These kids you consider on the spectrum, that's not a given. You come in and you hammer them with nonverbal gestures. I'm moving around, but I'm smiling at him. Mom, you smile at him. You say something to make him laugh. What does he do? Does he smile back? Does he give that back to you? You get a call on the phone. Your dad's died. Your kid comes in the room. You're bawling. What do they do there? A kid falls off the playground equipment. His head falls off. What does your kid do? Do they look around and be like, ooh, boy, that's not natural? Or what? What happens, right? A lack of interest in sharing enjoyments. They don't show off. Now, does he ever get up on the couch and just jump off and just love the fact that you're yelling at him? Think about your kids. They do this, right? Here's the biggest. A child in the clinic, I say, Mom, Dad, he goes out that door. 99% of kids, what do when they go out the door? They smile, they look over their shoulder. Why? Because they love being chased. They love it. They love the fact that you're going to come after them. It's a game. I see kids all day. They leave that door, they're never coming back. They don't care. They don't care if you chase them. They don't really drive. They might smile a little bit, but they're going to be in the parking lot in 5 minutes, and they're not going to be worried about it at all. I mean, I got a 6-year-old. He'll play a game until about 15 because I'm lazy now. I don't chase him anymore because I'm a bad parent. He'll get 6 or 8 feet, and then he'll start bawling and come back. How about this guy? Delayed and impaired communication. Listen to the speech. I want you to see what you think.
What's your name? Hey. Hey, you. What's your name? What's your name? Hey, sweetie, what's your name? What's your name? What's your name? Say, my name is Marshall.
My name is what?
How old are you?
We're all dirty.
How old are you?
Yeah.
Marshall, what's mommy's name? Marshall? Okay, you want to watch the movie of yourself now. Okay, say bye.
So he talks, right? He responded to questions. It's not autism? No way. Is that how your kids, the kids you see in the clinic, is that how they answer questions? Language delay. It's not just in kids, because oftentimes I'll see children who don't speak, but they will. They will, on some level, over time, with the right therapies. They will speak, but the way they speak, right? Like, it's intuitive for us. I finish a sentence that I want to demonstrate the importance of, I take my intonation down. They talk like this. It's a bouncy. It's described and sometimes as somewhat robotic in its intonation. Now these kids are anything but robotic. I don't mean to diminish that. But I'm trying to paint a picture for you that oftentimes is only clear after you sit in that spot for a long time. Numbers of presses. Difficulty of conversations. Mom, does he ever come into the kitchen, pull on your leg, eyebrows up, eyes big, blah, 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 and then you say, oh, I'm sorry, so honey, I don't know what you're asking. What is it that you want? And then they do it again, and then you say, I don't really know. And then they get mad and walk away. That is intent to communicate. That's me trying to tell you something that's happened, right? Another example, that's a child who maybe is angry, trying to communicate with facial gestures, might give you one of these, might give you eyes, might give you a yes or a no. These are compensatory mechanisms. A child who doesn't talk and doesn't compensate needs to be referred. Okay, because kids will compensate. They'll try a different avenue to get what they need to get done. They don't have conversations. They can speak. Oftentimes, children with autism speak. They can learn to speak. But the give and take, the perspectives of life. Hey, right now we're at a cocktail party. I'm talking to you, and then now you're talking to me. And now I'm backing away because I don't really care about renal physiology. And now you're in my space again. And now I'm looking over your shoulder trying to find out where you go. And then you just keep hammering me. And then I go to the cocktail, and you follow me. Right? I think part of that's endearing, and I really love working with this population, but I'm trying to give you a taste of what this tastes like. Unusual language. So I ask you a question, you respond with the exact same question. Or you insert a term that doesn't fit, like when you cut and paste on your documents, and you cut and paste something in the wrong spot. That's what they do. Hey Johnny, how old are you today? I like Blue's Clues. Good, great, what color is your shirt? I like Blue's Clues. Okay, all right, let's change the subject. Lack of imitative play. They're not going to take time to be like you. They will pretend to be your mom. They take a call on their cell phone. They might check their own email on their own little computer. Usually the answer there is no. Tell me what you see here. Stereotypical patterns and behaviors can be very subtle. And these are things that are often very difficult for me to document because we all think, oh, you mean hand flapping and head banging. Yeah, I mean that. But I also mean other things. Like, here's what I say. Imagine you and your husband go out for a date, and I come over to your house because A, I'm a pediatrician, I can maintain an airway to babysit, and B, I know autism, so let me come over. I'll come help out your house. So I come over, you guys are at dinner, I call you on the phone, right? And you hear screaming in the background, and I say to you, what's going on? What is going on? I just put him to bed, shut the lights off. He's freaking out. I don't know what's going on. And then you say, yep, forgot to tell you. You shut the light off, but then you got to turn it back on and off again 15 times. Then you got to turn around, you got to dance, and cover them up red, blue, red blankets. Sorry I left that out, right? That's a non-functional routine. And not only is it, you all have these. Some of you got some stuff that you do that you don't want me to know about. You know what I mean? Like I tell families, look, me putting my pants on, that's functional. It is. Me having some coffee, also functional, right? But there's other things that I might do that aren't quite so functional. But this is what pervades these children's lives. You don't do it, you don't comply with this non-functional routine, Control, Alt, Delete. Your day is done. Change the car seat to the other side. Take a different way to school, right? Put him in a clothes that he doesn't want to wear or she doesn't want to wear. Change teachers, right? Change temperatures. Change colors or textures of foods. Control, Alt, Delete. They don't just dislike it. They loathe it to their core. You see how I have to paint that picture? I have to know that this is impairing. You cannot get over this. Non-functional routines. Now, the kid on the left, this child here, that's not a typical play pattern. I have kids that age, they would take that ball and throw it at the camera. That's what they would do. And then I would put that child in timeout, right? The kid on the right, what I'm trying to show you there is there's a difference between playing with a man or chewing on a sword of the man. Playing with a car back and forth or spinning it over, putting it in your mouth, and spinning a wheel. My point here is globalization. How do you use toys? So when kids come into my clinic, the first thing we do is we set up toys. Before we even get in the room, we have two-way mirrors, and sometimes I'll just peek in and watch. You know, because this is the most natural this environment's going to feel for this child when I'm not in the room. How does he do? Does he pick up toys and chew on them? Does he show them to his mom? Does he throw a ball like you should throw a ball? Or does he just kind of run around with them and put them in his mouth and throw them in the trash? Preoccupation with parts of objects, that's also on the right. Stereotypical patterns, you know, this running, this hand flapping, head banging, things that you're not going to miss. To make the diagnosis, I can make this brief. You need 6 or more total items from the things I've just discussed with you. You have to be weighted in social problems. You have to have 2 features from social, you know, the social deficits of this to even begin to talk about autism. If you don't have any problem, if I read on your school reports that you're the most popular kid in your class, and you got all kinds of friends, your teachers think you do great, you transition well, I mean, it's just kind of we're done. You know, we're talking about something else. So you need at least 1 from that category, that's social deficits, and then you need at least 2 from there. You need 1 from each of the other 2 categories, which is communication problems and restrictive or repetitive patterns of behavior. It needs to not be other things. The classic DSM, you know, bailout is, hey, it can't be anything else. Can't be Rett syndrome, can't be disintegrative disorder. It has to be there before the age of 3. There's other things that you think about. Up to 40% of these children have intellectual disability. So what do I do when I make a diagnosis of autism? I send them to get cognitive testing, right? I mean, thankfully, you folks have good psychologists, I think, right here in the Ames area. But I don't know how they work with Title 19 insurance, which is the bulk of what I see. Really hard to get cognitive testing for those kids in central Iowa. A lot of these kids have seizures. Regression can be something that families can think about or watch for, especially if I catch it early between 15 and 18 months. I often tell families, yeah, they could regress further. 10 to 30% have large heads, and that has underlying genetic implications, which I won't go into, but it's not an atypical finding. So, now as we shift into 5th gear, make sure I honor your time. Identification and diagnosis. What would I want you to do? What would I want you to do? Well, first and foremost, continue to do the good job you're already doing in surveillance. And what that means is when kids come to the clinic for well-child checks, you are the front, back, and middle only. You are all the supports that are going to be available for this child until they get to school. And a lot of the kids I see, they don't do preschool until, I mean, usually I like to see it at 3, but sometimes 4 or even 5. Maybe you got a homeschool family. So these kids aren't getting immersed in same age peers. They're not going to get detected by school. And all they've got is 2, 4, 6, 9, 12, 15, 18, and 24-month well-child visits. And that's you. Okay, so what do I expect you to do? Continue to do surveillance. Mom, you got any questions? You got any concerns? Observe, watch this child. Is this typical for him? When I address him or her, do they turn and look at me? Do they follow a point? Just, it takes 30 seconds to do these kinds of basic prompts. I know maybe it's not as intuitive, but it certainly can be done. But then at 18 and 24 or 30 months of age, I'd encourage you to administer what's called the MChat. And I'm going to show you what that is in a minute. But that's a free online tool that screens for the core features of autism. And if it's positive, you can repeat it in, say, 2 to 4 weeks. If it continues to be positive, and I'll show you what positive means, that's a great reason to refer. And by referral, I'm going to close the talk with what I mean by that. So this is the American Academy of Pediatrics screening guidelines. So you're going to do developmental screening. I would encourage you to use the ages and stages within your clinic. I have a whole talk on developmental screening in practice. How you do it, how you get paid to do it, and why doing it is a really good idea. Okay? Even if they have Title 19 insurance, if you're not doing screening at 9, 18, and 24/30 months, you could be flushing $60 down the drain that you would get reimbursed to do a $2 screen. It'd take 2 minutes. Developmental screening, 9, 18, and 24 months, but then autism screening at 18 and 24 or 30 months, right in there, depending on when they'll come back. Okay, because usually you can only get reimbursed for the 24-month visit. And what happens between 18 and 24 months? Language, right? They go from a handbag of words, maybe 4 to 6 kind of expressive words, to 50 to 100, right in that age range, right there. So you're going to see it then. Okay, so the MChat is when you want to administer at that time. So the MChat is 23 yes or no questions. If they have 2 failures of critical areas, or they fail any 3 things at all, that's a failure in whole, and it needs to be repeated. I would say between 2 and 4 weeks, maybe a month or 2, but then I wouldn't certainly delay that. Here's the critical areas. Do they take interest in kids? Do they point? Do they bring you things to show you? Does any of this sound familiar? Do they imitate you? Do they respond? Do they point to toys? Things that you've heard me talk about. This is core criteria. Additional red flags. I'm going to go to the biggest ones here. By 24 months of age, I would expect a child to use at least 50 words. At least. And I'm talking, that's like the floor, okay? It could be hundreds, but at least 50. And that, if I had only one thing to tell you, is that if you have a kid who's not there, that's a kid that I want you to maybe follow up closely. Maybe do an additional developmental screening tool and see what kind of delay it is. Is it just language or is it global? And that's something that ages and stages can do for you. Okay, last few slides. Management. So it breaks my heart when I see a child who has been referred to us, and at the same time they haven't been referred to either early access if they're under the age of 3, or the AEA. Okay, so again, that'd be 3 and older. But really the whole thing is kind of AEA. Okay, so just Area Education Agency. These people will come into the home, they'll do an assessment, they'll provide free services to the family, and they will work with you as providers. They won't steal patients, they won't whisper nasty things in their ears about the medical community. I've had several discussions with these groups. They're wonderful, this is free, they come to the house as another set of eyes, and if they'll see it. If it's there, they'll see it. They'll see the concerns. Certainly, I try and get kids in preschool immediately. Immediately. I'm like, you know what? At 27 months of age, okay, maybe we can get you into Head Start. 33 months of age, okay, early childhood special education. Let's get rolling. Let's get going here. You're going to need the AEA to come in. They're going to have to put the systems in place to make that happen, but you need it because that's going to be the best therapy you can give them, is getting them immersed with same-age peers. AEAs have autism teams. Every AEA in our state has a team of people who specialize in autism, who know how to direct the curriculum of the schools to help these children reach their potential. Now, there's different levels, there's different abilities within these AEAs, but one thing I can assure you is that, like yourselves, most of these people love their jobs and they do it for free. They love it. So they're a valuable resource. And these are things that are all happening before I even see the child. Now, this is a caveat. I want you to hear this. This is really important. The wait list in Des Moines is not short, okay? Because 1 out of every 56 kids in the metro is now my problem. There's a lot of kids. But if I see a kid from your clinic between 18 and 36 months of age, and the chief concern is speech delay or autism, I will see that kid immediately, okay? We see him over the lunch hour. We'll see him at 5 o'clock, because that is the only developmental emergency that I can think of. Because if I diagnose it, we get the right referrals in place, we begin the workup, we start the therapies, we can make a world of difference. Now, you send an 8-year-old to me, a 10-year-old, a 12-year-old, I see this too. Is this autism, doctor? I hate to say it, but they're going to the bottom of the stack. Not because I don't care, but because I have got these kids that I can actually make a world of difference just waiting to be seen. So I don't want you to say, oh, don't send them to Des Moines because it'll be 6 months. That's true if you're sending me a learning disorder. and a seventh grader who plays soccer and has ADHD. I love seeing that. I don't have any problems, but they're going to go at the bottom of the stack. Because I have to be able to see those kids, 18 to 36-month-olds, the concerns autism, boom, you can expect those kids to be seen within a month. And if it's not happening, call our office and scream at us, okay? And I'll fire somebody. I have no power. I have no power at all. Psychiatry, psychology, these are things that I tend to line up. If I can't get them under control with medications, which I usually can, then we talk about additional referrals. Here's what we do. Early referral. Number one, one-to-one therapies. If it's speech, if it's a paraeducator, if it's OT because they have sensory problems or fine motor difficulties, if it's physical therapy because they have developmental coordination issues. Behavioral therapy can be very effective. We're adding that to our clinic in the fall at no cost to families. So you'll be able to see a PhD behavioral therapist who are able to say, Mom, I would try this, this, and this, because if we can get this behavior under control, then it might keep your child off an antipsychotic, right? Which is my goal. I want no meds for no kids.